It is my great pleasure to present today Dr. Aristea Galanopoulou. I'm going to talk a little about Dr. Aristea. She obtained the MD degree in the in the University of Athens in Greece, PhD in McGill University in Canada. At present time, Dr. Aristea is Professor of Neurology and Neuroscience and Director of the Laboratory of Development Epilepsy at the Albert Einstein College of Medicine. Her research is focused on epilepsies across the lifespan with a special emphasis and focus on infantile spasms and traumatic brain injury. She has received several awards. Among them, she received the Eli Ambassador for Epilepsy. Also, she received the Saul Korey Award on Translational Science and Medicine. At the present time, Dr. Aristea is involved in different committees of the International League of Epilepsy. But I want to say something important about Dr. Aristea. While she was chair of the Neurobiology Commission of Eli, she supported a lot different activities in Latin America. Also, when she was co-editor of the Epilepsy Open Journal, she supported the organization of a special issue about drug-resistant epilepsy with contribution of Latin America. Dr. Aristea, we are very happy that today you are our speaker. Please go ahead.
Thank you very much, Luisa, and here. And it's my pleasure to be talking to this group. And I've worked a lot with people from the Latin America region, and I'm always impressed by the level of activity, eagerness to change, research in the region. And I'm very happy to be working with you and always open to hear feedback and thoughts that you have about the things that we're going to be discussing or things that ILE should be doing for the region. I was asked to talk about the drug-resistant epilepsy, and this is in reference to recent efforts that probably you already heard about to reevaluate the terminology of drug-resistant epilepsy, which is something that is very important for epileptology. And I have here the slide of the current definition that we have. This was published in 2010. And the way that we currently define drug-resistant epilepsy is that this is a failure of adequate trials of two tolerated and appropriately chosen and used anti-seizure medication schedules, whether as monotherapies or in combination, to achieve sustained seizure freedom, with a note that seizure freedom is referring to freedom from all types of seizures for 12 months or 3 times the pre-intervention interseizure interval, whichever is longer. The original paper, position paper that was published at the time, it made very clear that this was intended for medical practitioners. And the main impetus behind this was basically to accelerate the time of evaluation of people with epilepsy who do not respond to treatments, to surgical treatment, and potentially also to clinical trials, and see if they can benefit more than that. As I will discuss later on, and this is something that many of us have discussed offline, this is a very valid purpose, but it does not solve everything about what we do, not only in the clinical practice, but also in research. There definitely have been benefits from the current definition. One is very broadly accepted and used, and that allows to pull together studies and reports and reassess them for outcomes or effects of drugs and so on. It offers a very simple common term to users of variable expertise. It has been adopted also by the community, patients, and caretakers. It prompts for drug-resistant epilepsy recognition, even from non-specialists. It prompts for consideration of other therapeutic choices like surgery. It has boosted research and interest on DRE, and I have here a simple graph of the PubMed hits that mention drug-resistant epilepsy. So there has been a very significant increase in the utilization of the term after 2010. And it offers a recognized endpoint for testing in clinical trials, permitting the comparisons. There are, however, gaps. It is very much anti-seizure medication centric. The choice of appropriate tolerated anti-seizure medications is subjective. Currently, the way that we operate in clinical practice, as you know, is we select treatments based on the syndrome, based on the seizure types, but not necessarily based on neurobiology or etiology per se. And this is based on evidence from population studies. In the preclinical research, it's a little bit different, and I will touch upon that later on, but this is a caveat. The partial responses and the impact on the quality of life is not discussed at all. It ignores etiology and mechanisms with very few exceptions. It is seizure-centric, does not reflect the heterogeneity and complexity of drug-resistant epilepsy. It does not fully address early diagnosis of drug resistance. For example, syndromes with poor treatment choices that may not even have two drugs to lead to seizure freedom, or conditions that we already know. Is the senior author on both of them that looked at adults with focal drug-resistant epilepsy in a study that followed the ILE criteria among 43 Italian centers. And the main message there is that if you look at the classification of drug-resistant epilepsy among the expert panel of the study group, the agreement was 90.1%, which is not unusual. If you work with people that have the same mindset and have the same experience, more or less, the agreement is the same. But when they look at the classification that the various investigators of those centers gave on drug resistance, the agreement was diminished significantly. And that also highlights the fact that some of the criteria that we use for the diagnosis are actually subjective. 45.6% was eventually classified as undetermined responsiveness by the expert panel in opposition with the actual investigators. So again, that's a caveat that we need to address. What makes it unclear, the diagnosis of drug resistance, is that sometimes we deal with poor compliance, self-termination of anti-seizure medications, breakthrough seizures, difficulty evaluating whether an event is epileptic or non-epileptic. The self-reported seizure freedom is not, as we know, always accurate, and we know that from the studies that use more invasive continuous EEG recordings, and the actual seizures that are detected from the EEG studies are many more compared to what the patients actually report. So it is possible that somebody may be self-reporting as seizure-free, but it may not be the case, and at some point we end up seeing that as a failure to attain seizure freedom. Tolerability issues are also important. Sometimes people cannot use the full dose of the medication that could be beneficial for them because of side effects, so we cannot assess fully whether a drug is fully tolerated and could have been beneficial or not, and also the subjectivity in assessing drug resistance. So a couple of years ago, in December 2024, following a publication that we had done stemming from the joint ILE-AES Translational Task Force, trying to call for reevaluation of the concept of drug-resistant epilepsy, the American Epilepsy Society and the ILE created a joint task force with 50% membership. And the idea is to develop a new proposal for the modification and extension of the drug-resistant definition based on task force discussion, engagement with key stakeholders, including people living with or caring for patients with drug-resistant epilepsy, and the community feedback. So this process is currently ongoing. We hope to be close to finishing by the end of the year. And probably many of you have heard me talk about this before, but it's never enough. And it's always a good possibility to hear your opinion about your thoughts about this issue, because we try to consider the community at every step of the road. This is the members of the working groups that we have assembled. And one of the first things that we've done is we wanted actually also to hear from the caretakers of people with epilepsy. And we had invited 4 caretakers, mothers of kids with epilepsy or patients with epilepsy. And we had a questionnaire that we addressed to them, specifically targeting the elements of the current drug-resistant epilepsy. What they said to us is the following, that there is a difficulty explaining the drug-resistant epilepsy term. Even if they look at the definition, the way that it is written in the paper, many of the terms are difficult to understand. And sometimes they can be misconstrued. For example, drug-resistant epilepsy may be misconstrued as futility to try new anti-seizure medications because epilepsy is not responding to drugs, which is not the case always. Failure often is misconstrued as failure of the patient to respond, and this is not what we want. We don't want more problems transferred to our patients. We still see delays in surgical evaluations. One of the caretakers, for example, was a woman who had a child with Rasmussen syndrome, which is a very bad epileptic condition that is treated with hemispherectomy. And even in that case, even though in that specific case, the diagnosis was done early enough for drug resistance, there was a significant delay until the time that surgery was done. And it's also the case for kids with infantile spasms, for example, which is another condition that can be highly associated with drug resistance. It is focused mostly in adults. In infants, drug-resistant epilepsy comes faster, and we see the aftermath much more severe compared to adults, because that's the ages that we want to see continuous improvement and maturation. And sometimes we don't, if there is epilepsy specifically drug-resistant. Etiology is not considered and should be considered. And also we need more individualized approaches. Not everybody is the same. Seizure freedom was a big problem for the caretakers. They could not understand how to evaluate seizure freedom based on the definition written in the paper, which was strictly referring to the medical doctors. It is very confusing, the intervention inter-seizure interval. For infants, even the weeks are problematic. They do not have the time to wait. And seizure reduction, control of some seizures can still be useful if you cannot have seizure freedom. This is not included in the definition at all. And I fully understand, and we have discussed it many times in the group, the idea was to basically push for the perfect treatment. But sometimes in an imperfect world, something is better than nothing. So we really have to consider the choices that we have to make. Another strong message that they gave us is do not change everything, because then you're going to lose the history. Even though 2 anti-seizure medications may not be perfectly separating the groups that do not respond at all versus those that respond with seizure freedom, they're still good because there's a lot of literature describing this group. And also it is easy to measure. For example, if you use a percentage probability to attain this much of seizure freedom after medication, it's very difficult to define. You have to look at the updated literature search, do your statistics, and see whether you fit there. But this is an easy index to grab and use and follow in the terminology. And I think we took that to heart because many of us also are doing research and we really don't want to just scrap everything and start anew, but we wanted to build upon what we have. And also they reiterated that it is important to consider improvements in quality of life in the way that we evaluate a treatment response and to consider more personalized care. Another reason is that drug-resistant epilepsy and even epilepsy is not a binary or a static concept. We may have, as I mentioned, partial response or incomplete response. You can have fluctuations. You can have periods that there is a remission for years, no seizures, and then they restart. For example, the temporal lobe epilepsy that starts from the pediatric ages, and the failure of the two anti-seizure medication schedules to affect seizure freedom does not completely preclude seizure freedom with the next ASMs, and this has been documented with many studies. It does not fully capture the heterogeneity and the dynamic changes of drug-resistant epilepsy across the lifespan and presentations or etiologies. It does not achieve earlier recognition of the drug-resistant epilepsy, does not consider mechanism or etiology, and does not harmonize clinical and preclinical research. Our rats do not live, rats typically live for 2 years. Having a seizure response assessment window of 1 year, it's beyond, it's a little bit infeasible. The partial response can be useful for some of the patients. And the responses, we classify that as drug response or drug resistant can also be changing. 20 to 38% of the people with drug resistant epilepsy may eventually enter remission. 16 to 58% may later relapse. And vice versa, as I'm going to mention another paper that studied that seizure freedom is also not static. It can also relapse. Here is just one paper that shows you that even after 7 anti-seizure medication, you can still have some even small chance of response to the medication. And this is what we see with sequential treatment. But another way of looking at that is that we never test the people who reach seizure freedom with different anti-seizure medications in the future. So once a medication, like for example, the first or the second works, we just stop. So we do not know how these percentages or whether a treatment would behave differently if in a patient who had a response or not. And this is a caveat because it's an assumption that we always make. In the drug-resistant epilepsy situation, is the progressive decline in seizure-free rates with subsequent drugs due to the progressive changes that diminish the drug's access or efficacy, or is it related to the refractoriness of the epileptogenic network or compromise of other brain networks that control seizures? We have a lot of clues about what drug resistance may mean. There's many different mechanisms. And for example, the special issue that your group had and Luisa had edited on drug-resistant epilepsy has covered a lot of those mechanisms, but it's never one mechanism for one patient. There's different mechanisms and there's different conditions that modify drug responsiveness. And I'll cover some of that later. So there's a lot of complexity associated to that, and we really don't have a strong clue in having very accurate answers always to that, which also explains the ambiguity in the classification of drug-resistant epilepsy in a significant portion of the patients. It is also very important to achieve early recognition of drug-resistant epilepsy. We know that more so from the pediatric epilepsies, because the development can be severely impacted the longer you wait until you control epilepsy, but it also can be true for adults. I mentioned this study because it gives an idea as to how long it takes to confirm drug response or drug resistance. So this is the Human Epilepsy Project study that enrolled 448 patients with focal epilepsy, 34 US centers. Seizure freedom was reached in 59.6% of the population. Approximately 10% had long interseizure intervals before the treatment, requiring at least 12 months without seizures to consider seizure freedom. This means that it takes significantly long period of time to confirm drug response. The median time to seizure freedom was almost a year. Most participants who developed drug-resistant epilepsy were identified at around 6 to 8 months. Higher proportion of individuals with high frequencies of seizures pre-treatment. This is shorter than assessing drug responsiveness, but it's still significant, particularly if you think about pediatric populations. This is almost more than half a year of a kid's life, and it's still a significant delay. Relapses are not uncommon. In the treatment-sensitive group that responded to at least to 2 anti-seizure medications, 14.2% relapsed and had more seizures after the seizure freedom. In the treatment-resistant group with seizure freedom after 2 anti-seizure failures, 38%, meaning 38% reached seizure freedom after they were initially classified as treatment-resistant. And a proportion, as I mentioned also earlier, were indeterminate. And also they identified risk factors, and this is also very important to start digging for the future research. Frequent pretreatment seizures were associated with higher risk for drug resistance, and self-reported comorbid psychological disorders were also a risk factor for drug-resistant epilepsy. And looking at things that may predict to some extent, or may provide models to predict drug resistance, may eventually allow to put the diagnosis of drug resistance earlier on, which may accelerate this process. So all this highlights the complexity of the story and the need to steer the research in a little bit different way so that we can get more answers out and provide a more accurate definition. We know from the pediatric epilepsy that conditions like Dravet syndrome, infantile and epileptic spasm syndrome, and other developmental epileptic encephalopathies, and not only there can be very early on recognized as drug resistant. Specifically for Dravet syndrome, there is no, classical anti-seizure medications that can lead to significant seizure freedom, but they do respond, kids with reduction of seizures. So the definition does not necessarily apply. And on the other hand, it raises the question that specifically for genetic etiology conditions, are we in the future only going to be talking about pharmacological treatments, or are there other options? And I'll mention some data that suggest other possibilities as well. And for the infantile spasm syndrome, there is a number of studies that supported that early treatment, early effective treatment and cessation of spasms and hypsarrhythmia may change developmental outcomes in preferentially kids who have spasms of unknown etiology, meaning not the structural etiology, but this is something, and there is a push to deliver effective treatments early. And as a note, the delay surgery is also utilized in kids with drug-resistant epileptic spasms, but it's still there is a significant delay to reach surgery in this population, even though the diagnosis of drug resistance can be given quite early. It takes almost like 17 months sometimes to push for surgery. So for the genetic etiology conditions, we all heard about the story with the antisense oligos. The poison exon theory is that within the sodium channel 1A gene, there is a specific exon that if it is inserted in the spliced product, it leads to mRNA degradation and less functional protein. And the group by Laurie Isom, starting with an animal model of Dravet syndrome, they found that by giving specific antisense oligos targeting this poison axon, they can prevent the production of the non-productive mRNA and shift splicing towards the productive mRNA, improving the expression of the sodium channel. And in the model, it had very good efficacy in terms of seizures and outcomes. And currently, this is in a phase 1 to 2A clinical trial with patients with Dravet syndrome. And the first data from the study were recently published in New England Journal of Medicine, showing that there may be suggestion of a benefit. The median reduction in convulsive seizures was 59% to 91% in the first 20 months. And there was an improvement in clinical status, quality of life, and adaptive behavior. So that brings into the equation that we're not talking anymore. Currently we still talk about this, but in a few years, the story is that it's not just surgery that can be another option for the drug-resistant epilepsy, but potentially genetic treatments for some of the conditions that we're going to have validated and approved genetic treatments. And there's a number of genetic studies currently in humans that are testing different constructs for genetic etiology epilepsy. So this is going to change the conversation in the near future, hopefully. The mechanisms are not just genetic, obviously, they're etiology. For example, there's specific pathologies that are associated with drug resistance. We heard about the hippocampal sclerosis and TLE, focal cortical dysplasias, and intrinsic epilepsy severity, epilepsy duration, the targeting specific pathogenic targets. What that means is that although now we're talking about drug-resistant epilepsy, in the future, if we implement more specific, let's say, genetic treatments, we'll also be dealing with genetic treatment-resistant epilepsy. There was a lot of discussion in our group as to whether we should be using the term drug-resistant or treatment-resistant, specifically acknowledging the fact that they may not only be pharmacological compounds as options for treatment, but also other modalities like genetic treatment. We opted not to do it at this time because we don't yet have a lot of, let's say, genetic treatments. But this is something that in the future it can be done. And we do know that this probably happens. We do know that from, for example, people who have tuberous sclerosis, they are given mTOR inhibitors to treat for the primarily the tumors and by proxy the epilepsy. And not, although there's promising results in the literature about better control of different types of seizures like infantile spasms in these conditions, we don't have the 100% efficacy. And this is not unusual because we know that once a gene changes, and I'll mention an example later on, many things, like a cascade of things change in the brain, and the differences from the control situation is further amplified. So it is possible that there's going to be additional treatment resistant mechanisms specific for genetic etiology or other specific etiologies that are associated with epilepsy. The network hypothesis is one plausible mechanism for drug resistant target hypothesis, the blood-brain barrier pharmacokinetic hypothesis, which also is intertwined with our ability to assess the response to specific drugs. Being able to interpret the results of success or failure to treatment is very important, and levels of target engagement is very important considerations in doing that. There's a lot of other modulatory factors. We hear about stress, we hear about cycles of biological factors, developmental factors beyond the brain, for example, the gut microbiome or other systemic biological systems. And many of those act in combination. So it's very complex as a story, and probably that's one of the reasons when we try to look at drug resistance, we just look at the outcome, not so much on the etiology yet, because we cannot probe them as effectively in humans. The other caveat is that we cannot easily apply the current definition of drug resistant in animal models. The seizure freedom definition is very impractical. The lifespan of our rodent models is very limited, for example, and the development of the animal is much more rapid compared to humans. It lasts a few weeks in rodents, and it's very difficult to assess drug treatments, and I'll show some examples later on in models of pediatric epilepsies. The models rely on partial seizure control because that's how it's easier to do, and we get good outcomes from that, but they do not necessarily translate on one-to-one basis to the seizure freedom in humans. Challenging to test sequential treatments for sufficient periods in animal models. There have been studies that have looked at sequential treatments, but it takes a lot of effort, significant cost, and significant sample sizes for some of those models, as we all know. But there are opportunities. They may explore mechanisms of drug-resistant epilepsy, and I would say the availability, for example, of etiology-specific models for drug-resistant epilepsy has been unique. And I mentioned the example of the Dravet syndrome, and there's also models that are modeling specific phenotypes that can be manipulated, like the sponge models. So there is significant utility in using the models despite these caveats. They may help understand a drug's effects, the relevance to a disease or clinical context. We can more closely assess whether a drug succeeded or failed because, for example, it hit the target, because a target was relevant or not in animals. It's something we cannot easily do in humans. It may introduce etiology or mechanisms in the treatment decisions for specific seizures or epilepsy syndromes, and it may provide more objective EEG-based documentation for efficacy. Most of the assessment of efficacy models is done with EEG, so it's by far much more sensitive compared to asking a patient in the clinic whether they had seizures the last month or two. And it's hard to compare the two conditions. It may help develop individualized decision trees in the management, and there is intense effort to develop, for example, biomarkers to assess epilepsy outcomes. Brain is changing, not just during development, but also during maturation and aging. It's changing depending not just on the intrinsic maturation processes, but also in response to the environment, like the lifestyle, stressors, other drugs that we deliver, other manipulations that we do, like enrichment. So it's really very fluid. It's a moving target. And comparing what happens in a model to the human, it's also another big challenge. The timing of the treatment also matters a lot. This is a study that was published back in 2008 by an Australian group that looked at a mutation of a GABA A receptor epilepsy in a mouse model. And what they saw is that if they had the mutation on always, this is the black triangles, the phenotype was actually much more severe compared to if you turn on the mutation around the post-weaning age, postnatal day 21. So the earlier you have a deficit, or by extrapolation, the more you have a patient with a genetic disease, for example, untreated, the more deleterious it is. And that makes a strong message to try to push treatments, effective treatments at earlier time point. And I have some examples that we also mention in the paper that we published to highlight the challenges of judging drug resistance and response in pediatric models, for example. You have a model. This is a classical model like that is the infantile spasms model, the models that we have a period, for example, that have spasms, and then a period that other types of seizures develop, and they may last through adulthood. And you start a treatment in one age, and you decide to do sequential treatment to see whether two anti-seizure medications work or not work in this model. So this is the time of the first treatment. This is the time of the second treatment. It may be that the evolution of the seizure type 1 may be too fast, and you may not be able to assess the same types of seizures with the two medications that you get. So this is a challenge because sometimes the effect of the medication takes time to amplify. It's not just 1 or 2 days that are going to give you the full effect. So it's difficult to call that drug resistant, or because you don't know whether treatment 2 could be effective in seizure 1. You have to have multiple groups and multiple complicated study designs to assess that. Another possibility is that you have a pediatric model of epilepsy. You have your treatment 1, you have your vehicle, you apply that, and then you stop the treatment when you see that there is continuation of the seizures, and you say that this is drug resistance. Unless you do probing of the specific targets of the treatment that you give, you have no idea whether this is drug resistance or whether this is inappropriate treatment because you don't have your target there. And I'll show you an example from our research in the lab. We have been using a model of infantile spasms, the multiple hit model, that we induce postnatal day 3. It has seizure spasms between postnatal day 4 and 13, and then other seizures later on. And we have been using that to study a lot of investigative or clinically approved medications. And one of them, back in 2014, we published on a galanine analog, NAX5055, that preferentially targeted the galanine receptor 1. It activated that. We found no effect. So normally you would call that drug failure. When we looked at the expression of the mRNA for the receptor 1 of galanine, we saw that the expression is actually very, very, very low as compared to the receptor 2. And if you look at the developmental expression, the postnatal day 4, the time that we gave the medication, the expression was very low as opposed to adulthood. So this is an example of what I mentioned before, that sometimes the lack of effect can be just irrelevance to the existing target or mechanisms of the disease. Another example that also brings relates to the discussion about validating treatments in different models. We always discussed in the translational task force that before you go into a clinical trial, test the efficacy of your drug in different models to see if indeed it is valid. So this was an interesting story. There's a different model of infantile spasms using an ARX, Aristeas X-linked homeobox. It's a mutation, knock-in mutation that has been identified in X-linked infantile spasm syndrome and some other developmental and epileptic encephalopathies. And Jeff Nobles' group generated a mouse model. So what they found is that neonatal estradiol given between postnatal day 3 to 10 was actually very effective in preventing spasms and epilepsy, restoring the interneurons in the brain, providing NPY but not parvalbumin. It restored the striatal cholinergic interneurons. And the trick was that this treatment had no effect if it was given at a later age. And they proposed that this was a promising treatment for ARX. An Australian group, in collaboration with Jeff Nobles, used 2 different other models of ARX spasms in a mouse. The one had the PA1 expansion, the other the PA2. And what they noticed is that the same treatment with estradiol between postnatal day 3 and 10, in the first model, the PA1 that was similar to Jeff Nobles, there was no severe myoclonic seizures at 7 weeks, so that's a good outcome. The second one that affected the polyalanin stage 2, what they saw is the treatment triggered earlier onset of seizures, but it reduced the seizures later. So overall, good or okay effects, but with some variability depending on the specific genotype. Regardless, there is interesting because we don't have many treatments that can affect disease modification or treatments. So there was a lot of interest in seeing whether that can be applicable in other models. And at the time, we were part of the Cure Epilepsy Infantile Spasms investigator group with different research groups working on infantile spasms. And they asked us and other groups to utilize this treatment in our models. So long and behold, when you give this model to either the betamethasone, prenatal betamethasone, postnatal NMDA model of epileptic spasms, this is a rat model of acute spasms that has also been used. There was no effect. When we gave it to the multiple hit model of infantile spasms, there was no effect. So the questions that come here could that be a promising treatment for the specific etiology, ARX, but not for other etiologies like these non-ARX related conditions with infantile spasms? It could be. If you say that it could be, then you go back to the data from Jeff Nobles. The big question is, how does the postnatal day 3 to 10 translate into the human condition? Because that would be critical. I mean, you can imagine that you would have parents with boys with spasms that have the doctor telling them to prescribe estradiol. So we really have to have a better guidance as not only to whom a treatment can be effective, but also when a treatment can be useful, like here, and how can we use biomarkers or diagnostics to select patients that can actually benefit the most from those very specific, probably individualized treatment approaches. And we're not there yet. Another example that I like to give about drug resistance is actually a clinical trial. You may remember a few years back, it was in 2010 that it was published. That's the phase 3 trial on Carisbamed. It was done on 2 cohorts, multi-center cohorts, same study design, and patients had drug-resistant epilepsy, and the investigators asked to see whether different doses of Carisbamed were effective. And what they found is that there was efficacy seen in cohort 1, but not so much in cohort 2. And then looking at the details of the study, they saw that perhaps cohort 2 had a little bit more, had a different composition of patients that received inducing versus non-inducing anti-seizure medications. And that could potentially be one of the factors that could prevented cohort 2 to show efficacy, because the Carisbamed was metabolized more and probably the effective levels were not as high. And again, that's the importance of when we're faced with a failure, it's always worth to see what the failure is due to, and vice versa, when we're faced with a success, to see whether this is a true success or not. And this is something that the clinical trialists have to continue incorporating into their study design. Another aspect is how much of what we observe as a response is luck or true response. This is another example here. We have a model, we have seizure 1, then there is a period of remission, and a seizure 1 again resurfaces. If we give treatment 1 and we're not very careful, we can perceive that as a drug responsiveness. And then we give treatment 1 in the future and we perceive that as a basically drug resistance at that time. So should that be interpreted as early response to medication and subsequent drug resistance because the brain changed or something else happened? Or is it due to simply natural remission of the seizure in this epilepsy condition that accidentally appears as a treatment response here? If you don't have ways to track the treatment response, either if you are able to use target engagement, multiplication, or other means of assessing the drug effect, it's very difficult to evaluate. And although you can get suggestions by high sample sizes of your trials, but there's also a significant confounder presented in this manner. And as we know, there's a lot of reviews about epileptogenesis and the mechanisms and the stages of epileptogenesis, but also beyond the brain, there is additional factors beyond the epileptogenic substrate that can control seizures. For example, you can have stressors that when they appear, they trigger seizures, and the same epileptogenic substrate is not always producing seizure activity. Our patients do not have seizures continuously, but they have specific time points that they manifest seizures. So those extrinsic factors perhaps can be considered, and perhaps we can, now that we're more into the habit of using big data analysis, we can use this kind of multimodal predictive models to predict not just treatment response, but also treatment resistance. So in essence, to change the way that we practice research and medicine, I think we have to try and incorporate in what we do a little bit more rational steps and markers of what we do and how we assess the responses, identify target mechanisms, target relevance, engagement, what is the appropriate therapeutic window, and more specifically, identify target populations that would be eligible for the treatment, and that would allow probably for more individualized approaches and more accurate and truthful studies. And beyond that, we also know that the complexity is also the cell type size, which different cells behave in a different way in terms of somatic mutations or other connectivity and so on. So it is, for us, we do preclinical research. We need to be able to answer these questions before a drug that we find promising is delivered in the clinical trial arena, about who, what, when, and how to treat, what's the best treatment, the safety, efficacy indications, PK/PDs, therapy targets, biomarkers, and who will not respond. And on the contrary, the clinical trialists will have to try and use as much as they can and they have available to inform the accuracy of the outcomes they describe so that we can compare data, and we shouldn't discard good drugs and we keep the ones that need to be kept. So when a failure may not be a failure is important, when a success may not be a success is important to evaluate. And that's where the biomarkers are coming into play. We have a lot of interest in biomarker discovery, and we've been using extensively, for example, the post-traumatic epilepsy model to identify biomarkers for epilepsy and eventually drug resistance. And I think the future would be to develop this kind of validated models to inform. And I have to say that it's something that I remember when we started the effort with the Translational Task Force in 2012, we kept quoting the experience from the cancer field, that they had a lot of markers, a lot of genetic genotypes, and a lot of guides to help them rationalize the next treatment plan and predict who's going to be having a good prognosis or not. I don't think we have that yet in epilepsy, but I think this is something that needs to be more pursued so that we can have better ways of treating patients and developing therapeutics. So going back to the way that our task force operates and what we're trying to do, this is just a depiction of epileptogenesis. As we know, there is etiology, initiating event, precipitating event, pathology, so network remodeling that contribute to epileptogenesis. First clinical seizure happens, epilepsy diagnosis is placed. At some point, drug-resistant epilepsy diagnosis is made and surgery is done. Throughout this process, there is a lot of predisposing factors and modifiers, including of drug resistance. And what we basically try to achieve is try to utilize much of that information to see if it can help us bring the diagnosis of drug resistance earlier. So this is the current clinical management. It's very simple. And what we what we're discussing in the current drug-resistant epilepsy joint task force is to look again at the seizure freedom and anti-seizure medication schedule, although it is unlikely that we're going to change the rule of 2 ASMs. At least we need to have an updated view of how the subsequent response to a new anti-seizure medication alters the rate of seizure freedom and the likelihood of sustained drug resistance or response. We are having a group that is looking at the value of partial response to treatments and quality of life measures. Is there a way of putting a condition in the definition that may actually provide some reference to partial response, because that will be not only a little bit more hopeful for the patients if you tell them that something may or may not alter quality of life, but also it can provide a bridge with what we do in the preclinical field, because it's easier to judge partial response with partial response rather than partial response with seizure freedom. And also we're trying to look at conditions associated with early drug-resistant diagnosis. For example, some brain tumors, some dysplasias, or pediatric conditions like genetic etiology. We already know that are highly associated, and likely this is going to be an additional statement alerting that in certain conditions you don't necessarily need to wait for 2 ASMs to call drug resistance. And in a different subgroup, we try to provide a translational perspective with the idea of realizing that we're not going to be completely taking the clinical definition. We try to steer some directions as to what are the useful directions for the preclinical research and how can we use those to provide translational bridges between clinical and preclinical research. For example, the biomarker data would be a very nice approach. In this, the etiology-specific models of drug-resistant epilepsy could also provide very useful insights and so on. There's an open question, as I mentioned already, about how to integrate non-pharmacological treatments, in the future genetic, but this likely is going to be a task for a subsequent task force when we have more data based on that. And we try to keep in mind the advice of the caretakers and make the language more clear, the terminology is more clear, and incorporate meaningful outcomes, and so on. So the latest direction that we have approached is we're leaning towards highlighting the conditions that can provide high risk for DRE versus DRE diagnosis, plus incorporate the partial response in QOL measures. And this is basically an overview of where we are right now. There is a session at the European Congress, for those of you who are planning to come, that we're going to be discussing the progress in the working group, but more so an attempt to collect feedback from the community, because this is very important for us. And we hope to, we have ongoing literature searches to get some more data-driven approaches to what we do. And I think I'm going to stop here, and I will be happy if there's any questions from the group to address, or any suggestions or thoughts about the drug resistance. Thank you very much for joining us today.
Thank you so much, Aristea. I wonder if there are questions. For a while, I want to ask you the relevance of social aspects, because these are not included in the definition. In some way, social aspects are very important in regions like Latin America, because regions like Latin America present a high prevalence of drug-resistant conditions, especially in areas with very low resources. In this way, how about to include different definitions of drug-resistant at different levels? For example, one including only social aspects, other one including therapeutic responses. What do you think about that?
I think it's an important topic. I'm not sure that we'll be able to include that in the definition beyond the context of the quality of life, but it's a critical point that needs to be addressed. And we have that also in the United States. For example, it is not uncommon that when you deliver a diagnosis of epilepsy, and more so drug-resistant epilepsy, you have some of the patients directly just give up work. They go on disability. the fact that they cannot drive, it's a big limitation. And that changes negatively, I would say, the way that they may respond to treatment, but also the quality of life. I think it's an important issue to be addressed, probably separately because it's very complex. But I fully agree that this has to be improved. And I keep thinking about the way that pediatric epileptologists manage pediatric epilepsies and how we as adult epileptologists manage adults with epilepsy. A kid who has epilepsy, they have special education, they have the parents on top of them, they have a lot of stimulation, physical therapy, occupational therapy if they need to. There's a lot of attention, and there's still a lot of improvement if they find a treatment. None of that is necessarily in place in adults as extensively, and I think that is a major area that needs to be revamped in therapeutics. So I fully agree with it.
And probably we have to consider some procedures to be included in preclinical models, because we use animals in excellent conditions, but probably we need to use animals under stress conditions or under bad nutrition and so on. And other question from my side is that probably in the future, it could be essential to identify if a drug is inducing by intracellular responses, if a drug is activating the transductional mechanisms in order to be identified in vivo in patients, because probably that is the best situation to know if one patient is or not drug resistant. Unfortunately, it is impossible at present time to detect intracellular changes in the human brain in vivo.
I fully agree. And if even if we were able to do that, and we see that also in the animal models, that sometimes we are able to see that what happens in one brain region and one cell type is very different than another. And I was doing a few years back research, as you know, on GABA A receptor switch from depolarizing to hyperpolarizing. And that's a classical example that not every cell behaves or matures the same way, and not every cell responds to seizures in the same way in this particular signaling pathway. And putting everything together, it's really challenging. I mean, I keep reading, and all of you have read the network papers, computational network, and they look very nicely on the piece of paper, but trying to bring that into a biological relevance or functional relevance, it's very challenging. So I agree we need more tools. We've looked also to see not just for intracellular pathway, but whether changes that happen in the brain can actually be detected by peripheral biomarkers. They're not always detected. They don't always follow the same direction of change. So, but hopefully, it takes a lot of stamina and insistence, and hopefully we're going to find more tools to help us with that. Like a Star Trek Next Generation with a probe in the brain to see what you need.
Yeah.
There is a question, I think, do you think they represent distinct mechanistic pathways converging on the same clinical phenotype, or is drug resistance typically multifactorial with several mechanisms coexisting within the same patient? I would say both. It's multifactorial. I mean, I don't think there is a single study that studied every single putative mechanism of drug resistance, saying that there is a single mechanism related. I mean, we do know that all of the candidate mechanisms of drug resistance are continuously changing, and they can act synergistically to do that. So I would say probably multifactorial, which makes it even more difficult. So thank you, Daniel.
Thank you.
And Gisela, in light of these new definitions, how relevant are animal models? I can only strongly suggest that they are relevant. I mean, I know that it is challenging to translate, but that's the only research that you can control conditions and get answers. And if you do a good study design, you can get answers that can be eventually taken further to the clinical. So it needs patience, and we need to be advocating for preclinical research, ethical preclinical research, but we also need to put it into a perspective, realistic perspective, not science for science, but science to change the way that people are affected by diseases. I think that's a very important goal.
I have my own questions, but first of all, thank you very much, Aristea, because it was super clear, the talk, and super nice. In YouTube, we had a peak of 20 something people. Now there are less, so I open the questions there. There are no questions there, but just in case someone wants, I will read it. My questions are basically two or three. I'm gonna go with the first. The first one is we always think in the self-reporting by the patients or the caretakers. Is there any idea of automatic devices to translate that directly to the research group or to the hospital or whatever? Like, I don't know, smartwatches or anything. I know they are in the market. They are not so good, maybe, but they are in the market. But the self-reporting is always something that makes some noise in my head, like you always depend on the awareness of the patient or the caretakers to detect that. Is there any, and I don't know, official idea to try to put that in more black and white situation?
That's a very good question. I mean, there are some devices that allow long-term, for example, EEG monitoring in humans, not necessarily now with depth recordings, for example, subcutaneous EEG. So this is something that in some places it's been used, not widely. So that potentially could be a tool to have a little bit more objective assessment. The other population that people probe is the people who already have neurostimulators, like responsive neurostimulators that continuously record seizures.
Yeah.
And there are groups that actually use these patients for trials. Another very smart device, and I mean, you'll know about the wearables. There's positive and negative experiences from that, depending on the seizure types that you have. If you have, for example, seizures that are mostly, impaired awareness, it may not be as useful. If you have strong motor seizures, it's a different story. But the other smart tools is AI generated. So there was a meeting recently, curing epilepsy meeting by NIH. There was a very nice talk, inspiring, by a parent of a kid with developmental epilepsy and epileptic encephalopathy. And what she decided to do is to develop an AI-based tool and founded a company that actually can track the daily experiences of patients. Plus, it can guide and remind them to take medications, appointments, and it's an interactive tool. And the Epilepsy Foundation of America also had a kind of a cloud project trying to incorporate different factors as to how they would be affecting the incidence of seizures in patients with epilepsy, exactly with the idea of getting this kind of multifactorial modifiers of seizure. So we're getting there. I cannot say, that's the closest that we are right now. I know that there are experimental groups. I don't think they're used already in humans that try to look at the video behavior and screen the behavior and they can extrapolate whether this is a seizure or not. But again, that needs a very specialized research group. It's not something that is widely applicable. So hopefully in the future, things are going to be different.
Yeah. And my other question is the in and out patients that maybe became resistant, and then they add, I don't know, ketogenic diet, they change the anti-seizure medication, and then they go back and they get seizures and no, because when you speak with patients, it's like, it's not black and white again. It's so difficult to separate everything. How is that is going to be taken into account in this idea? Because they don't fit in the categories of 2SM and didn't work, so it's drug-resistant epilepsy. Maybe they added something, or they are in and out in the ketogenic diet. It's very very complex to fit them in categories. No, how do you think? I don't know if there are any clue about that. How do you think we can put that patients in categories, because it's so difficult?
It is difficult, and that's exactly that we don't try to put that there, because ketogenic diet is very helpful. The efficacy becomes better with time, but we're not talking about reaching seizure freedom necessarily, but it does improve the seizure outcomes. But if you think beyond that, it's not just ketogenic diet. Remember a few years ago when everybody was excited with cannabidiol? People use cannabidiol not for medicinal purpose. And then you try to, and when we have, particularly, for example, in Bronx that I practice, in one of the hospitals that I have, I'm not even asking, are you using drugs? I'm just saying, you haven't used any drug. It's so common. So it's a multitude of nutrients or other drugs that are not prescribed, or other factors, activity, that can interfere with the seizure incidence and protection or not. So, and that's the point of trying to put real life data into our assessments, because it's not just the drugs. With the clinical trials, we try to cut down on the noise by increasing the sample size of the population. So maybe the individual impact of those confounders is diminished. But when we have a patient in the clinic, that's not the story. We really have to keep asking detailed questions, and for some of them we don't know.
Yeah. There is, thank you, Aristea. There is another question in the chat. If you want, you can read it. Your action is going to be better than mine, sure. So if you want to read it.
I don't think I see it.
I'm going to read it. What do you think is currently the biggest translational gap between animal models of drug-resistant and drug-resistant epilepsy in patients? Is the heterogeneity of the human epilepsy treatment history, chronicity, or are we simply not modeling the right mechanisms?
Yeah, it's a good question. I would say more. One is the heterogeneity, the other is the different substrate. Humans are not the same as animals. And even if we think about the way that we give the treatments, for the humans, we start gently and we go up. We don't have that patience in the animals. We just load the medication and see the effect. The tolerability is not so easily assessed on all. We can assess some measures of tolerability and side effects, but there are other measures that we cannot, like the immune system reactions. Animals are notoriously bad to assess that. So I think it's a combination of heterogeneity, but also of the different biological substrate and different lifestyle as well that animals and humans have.
So I don't see questions in the YouTube, or at least I cannot see them, but I think there are no. So
no more questions. Thank you so much, Aristea. Really, we appreciate a lot this conference in LATEP.
Thank you so much for the invitation. It's been a great pleasure being with you.
Thank you very much. Bye-bye.
Bye.
Bye-bye. you.